Thank you, Heather, and thanks to the CDG Care for inviting me. I'm delighted to be here and honored to be here speaking with you all today. I'm just as background, and I appreciate Heather and Matt keeping me on target today time-wise, because I think the most important thing is to give a chance for questions from family members, and I'll appreciate your questions either during the presentation or during the break. Sometimes it's hard to ask some questions about reproductive health in a big group, so I'm happy to talk one-on-one also. And I share my Minnesota background with Heather and Matt, and grew up in Minnesota, and then trained in the Mayo Clinic, and then came to the NIH after working in the Mayo, Arizona clinic. And so I've had a chance as a fellow to work with Donna Krasnowich, whom some of you I think know, and I'm just delighted to be able to see patients with CDG as part of my practice in the National Institutes of Health. So a lot of the patients, one of the best parts of my job, I have to say, is working as a gynecologist for patients with various rare diseases and gynecologic syndromes and even undiagnosed diseases. And one of my favorite parts is being able to work or be a part of advocacy groups and speak with parents. It's really a delight, and I'm always inspired by the parents who are running these groups and spending a lot of time and energy trying to help research move forward and also provide educational experiences. And so today these are sort of the general topics that I want to talk a little bit about, some of the prepubertal and pubertal development, and a little bit about some of the medical issues that come up as a result of CDG within reproductive health, and then talk about routine care and routine gynecologic care and why that's important, and what some of the challenges are both for patients and families and also providers. And then talking a little bit about a good resource that I think is great for families to use. So prepubertal gynecologic findings I'm using this is from Dr. Lamb's great article that just from 2018 that shows some pictures from the NIH study that Donna Krasnowich and Lynn Wolf provided with inverted nipples, and then the suprapubic fat pads that you can see here that usually resolve, and then also other abnormal distribution of fat are just the findings, sort of the classical findings that people talk about within CDG. And then moving on to pubertal development, quite a high percentage of females with CDG lack secondary sexual development, primarily in the PMM2 group because of the hyperkinetictropic hypogonadism, which is a long word, which basically I'll get into in the next slide, has to do with differences in glycosylation of some of the hormones. But normal pubertal development is also described within CDG, and CDG is such a wide range of different disorders that it's important to sort of address a wide range of possible pubertal development within girls and women with CDG. So just a little bit about the hyperkinetictropic hypogonadism. So basically, all of the hormones, let me get this to work here. So it might seem complicated, but this is the scheme that gynecologists usually look at for hormones, with the hypothalamus in the brain, with gonadotropin releasing hormone acting on the pituitary gland, which then releases two hormones, the follicle stimulating hormone that people call FSH and luteinizing hormone that people call LH. And then that acts on the ovary, which produces the estrogen. And so there's feedback, positive feedback mechanisms and then negative feedback mechanisms. And so within PMM2, the abnormal glycosylation of the FSH and LH that comes from the middle pituitary here is thought to cause the reduced availability of those hormones, and then a lack of decreased estrogen. So the hormone finding is decreased estrogen and then elevated FSH and LH that aren't necessarily acting in the way that they need to be for the puberty to take place. And that can lead to delayed or even absent secondary sexual characteristics like the breast development, and then the start of menses, which is menarche. So patients then are described as patients that have delayed or no development of menarche and have the hormone findings that I just described are described as having primary ovarian insufficiency, which is, the acronym is generally, people will say POI, and it used to be, and it's considered the same thing, premature ovarian failure. And the language just within gynecology has been changed over the past several years to POI, but basically it's amenorrhea or no menstrual periods, or oligomenorrhea, very few or infrequent menstrual periods, and then an elevated FSH hormone. And one of the problems that we see with this, with decreased estrogen levels or estradiol levels, is incomplete bone mineralization. So this can be a problem with studies showing that this lower bone mineral density seen in women with POI or early menopause, which is generally considered under the age of 40, is that there's due to any etiology from whatever, so all causes, and there's a lot of different genetic causes of POI, a lot of which we are still identifying. But this is associated with an increased fracture risk. So that's one of the biggest concern. And a lot of these studies demonstrate that the fracture rates are reduced amongst women with POI if hormone replacement therapy is used. So that issue comes up and is a little bit more complicated in patients with CDG who have the type of CDG and PMM2 that have an increased risk of blood clots. And so it becomes a complicated mix of risk and benefit ratio. And so the mobility issues also, like with other disorders, can impact the bone mineral density and the fracture risk also. So I know a lot of a patient that I have seen recently at the NIH who had POI and also mobility issues and was placed on estrogen. And the issue came up, should she be on estrogen because she has an increased risk of blood clots? And I know there's, with Dr. Miller and other experts within the field, a lot of discussion about this and how much estrogen should be used and then what form of estrogen, and we'll come to that in a couple more slides. But the reports, one of the papers that Dr. Krasnowich had written describes one of her patients who's a 33-year-old woman who had a DVT and a PE. So those are just acronyms for deep venous thrombosis and pulmonary embolism. So the blood clot risk can cause a blood clot in the legs that can then go to the lungs and can be a big problem and has been seen in this population. And so it's an issue that it's not resolved because there's still it's a risk-benefit ratio that has to be addressed with the assistance of an endocrinologist in addition to the primary care doctor. So basically, though, within the gynecology community, generally people believe that appropriate hormone replacement therapy is needed to replace the premenopause. So these are young women, maybe even teenagers or in their early 20s who don't have enough estrogen. And so there's a sort of a belief within the POI community of healthcare providers that providing estrogen replacement therapy is very important for not just for bone health, but for cardiovascular health and general well-being. And so the transdermal estrogen is often thought to be less of a risk of a thrombotic event. And one of the people that studies POI in our country, Larry Nelson, who was at the NIH until recently, recommends transdermal estrogen, so an estrogen patch with 100 micrograms per day of estrogen. And then because if you give estrogen alone, there's a risk when somebody has a uterus, even if they have early or premature ovarian failure, there's a risk of endometrial hyperplasia or building up of the uterine lining if you don't use progesterone. That one of the recommendations is to use an oral progesterone pill for 10 days of the month. And so the alternate recommendation that a lot of the adolescent gynecologists across the country are using more now is a transdermal estrogen patch from 50 to 100 micrograms with a progesterone IUD. And so and I'll come to the IUD a little bit later in the talk, but that's a progesterone IUD that slowly releases progesterone within the uterus and helps protect the uterus from the effect of estrogen. And I have a patient the patient I mentioned before who is on, who also, a PM, has PMM2 CDG, is on estrogen, and her endocrinologist and gynecologist decided not to put her on progesterone, and instead they do a pelvic ultrasound every year, 1 to 2 years, to make sure that the lining of the uterus is not getting thick, putting her at risk of the endometrial cancer. So the risks of HRT, it's complicated in patients who are also at risk for the blood clots, and that consulting an endocrinologist is important. And when I talked to Donna Krasnowich before I came, she said, make sure you tell people if their daughters are at risk and are on estrogen to learn about the signs and symptoms of a DVT, which is redness and swelling, redness in the leg, and pain. So this is from Dr. Merideth's paper, and I just wanted to describe from what they described of the 29 females presenting mostly with delayed, incomplete, or absent puberty, and no periods at all for a majority of them, but there were 3 females with normal puberty and normal menstruation, so normal menstrual periods. And then other patients who have some spotting, and they'll seem to be entering puberty, but then don't continue with a normal pubertal development. And then, interestingly, 27 females, they described in their group of being treated with estrogens to induce puberty, and that no thrombosis was reported amongst those. So I think that it's a field that probably more research is needed to give more information to guide families. And I would, there's another paper that describes a French group that describes a large cohort of patients and talks about their findings in the females. And one interesting thing that I noted from their work is that they talk about there not being really, it's hard to predict. There's no sort of genotype-phenotype correlation. In their description, they talk about how there are also a few of their females that had normal puberty, and it doesn't seem to correlate with degree of intellectual disability. So it's a little bit hard to predict, or it's hard to really understand. I don't think it's completely well understood why there's a difference and what the difference is amongst the patients that are having a normal pubertal development versus not. So routine gynecologic care, it's an important aspect of care for all females. And adolescents and adult women with CDG have special and diverse needs. And it's important for the clinicians taking care of the patients and doing this part of the care to recognize these special circumstances and needs, even in the setting when they haven't taken care of patients with this particular disorder. So the factors that can affect care: fear of an exam, probably the fear from the parents and from the individual, limitations in the cognitive ability, and even the question of, is this person going to be able to tolerate an exam in the office? And when I meet patients at the NIH, if they're there and I've never met them before, I'll sit down and talk with the parents, because the parents will have the best idea. Is this something to even consider? Because it's important to only pursue it if it's something that is not going to cause a problem or trauma for the patients. And sometimes the patients will have been taken care of in the community and undergone a pelvic exam that really just didn't go well. And I had a patient earlier this week actually with a different disorder, and that was her situation. She was 22 years old, and she had her first pelvic exam within the last year, and I was talking to her about it, and it really was a very difficult situation for her, and it didn't go well, and then that can last for years. And so that's something that I really sort of strive to avoid, because once somebody's had that experience, it's hard for them to get over the fear then for undergoing pelvic exams in the future. So counseling can help to alleviate the patient's anxiety in some circumstances, and it depends. It's so patient dependent, like explaining what will happen during the exam. Sometimes I'll see a family and the patient and go to the GYN exam room and look at the speculum, look at what the stirrups look like, look where you'll be sitting in the exam table, and talking about why we're doing that, or maybe looking at a diagram, or using pictures, models, dolls. Some clinics use a special anatomically correct doll to talk about it. It sort of depends on the patient and what would be helpful for the patient. And having a support person present, sometimes the patient will want a certain person there to help them through it, speaking in a reassuring voice and trying to keep a calm clinical office setting is, I think, very important. Not having people walk in and out of the exam room, and sort of being deliberate about the setup, I think really can make a difference. And I think, hold on just a second. Okay, so using the smallest speculum possible. So there's various sizes of speculums. There's the tiniest pediatric speculums. There's some that are very narrow but longer. And so just kind of having it set up ahead of time and going to an office where they're kind of used to having patients of different types which sometimes means an adolescent gynecology clinic sometimes is a little bit more equipped for this kind of a setting. And then for some patients, doing deep breathing exercises. I've had some patients put on headphones and listen to their music. I think it depends on the person what they want to do. And I have a patient population of a different disorder that I've done quite a few first pelvic exam experiences, and those patients are generally in their early 20s. And I'll talk to them ahead of time before they come to the NIH and make sure they bring with them their favorite, if it's their blanket or a favorite stuffed animal, and that seems to sometimes bring comfort to people during the exam. So the recommendations, this is the general recommendations right now for Pap and HPV tests, and this is through our American College of Obstetricians and Gynecologists, and that's who generally sets the guidelines in this country based on science and evolving science and evolving technology. And the recommendation now is to start Pap and HPV tests at age 21 years. And in the general population, regardless of sort of when sexual activity is started. And so then the recommendation is for Pap every 3 years, between 21 and 29 years, and not do HPV testing. So HPV is human papillomavirus that I'll talk about in a minute. But then from 30 to 65 years, doing combined Pap and HPV tests every 5 years. It's also acceptable to do a Pap without the HPV every 3, but I think most people are doing the HPV tests. And so in talking to a provider, a gynecologist who works at the University of Michigan who does a lot of special needs populations, I was asking her if she thought that the guidelines should be different for patients with disabilities. And her comment to me was, given health disparities for women with disabilities, we try to make sure the quality of care for our patients with disabilities meets or exceeds the standards. So I guess it gets a little bit trickier in situations where it's very difficult to obtain do a pelvic exam and obtain the samples. And she mentioned to me something interesting, which I wonder will be waived for the future. She has a trial right now where she's doing self-obtained swabs. So the patient and their caregiver will obtain a swab for HPV at home or out of the office setting, and then that'll be submitted for HPV testing, and that can then prevent them, or that can eliminate the need for doing a speculum exam at least. So maybe that will be something in the future that will help. So the special considerations for Pap and HPV tests, we need to assess first if the exam is possible for the patient in the office setting, or is even possible to even explore with the patient. If sedation is required, it's definitely preferable to do it at a time when the patient is already undergoing sedation, like for a dental procedure, or at the NIH if they're getting an LP or some other procedure that they're already undergoing anesthesia. We can just add a pelvic exam, which in that kind of a circumstance generally would add like 5 to 10 minutes if you kind of get all the supplies ready ahead of time. And then it's important to consider risk factors, including possible sexual activity, and then also that evaluation is needed on a little bit more urgent basis if the person has abnormal vaginal bleeding or some concern, or a concern for abuse. So patients that do have menstrual periods, potential menstrual hygiene issues can be the reaction to having blood on the fear or dislike of pads and seeing the blood on the pads. And I think the patient I had earlier this week changes her. I asked, how often do you change the pad? Because it gives you an idea sort of how much menstrual blood there is. Do they have heavy periods? And that patient the mom told me she changes a pad every time she goes to the bathroom because she doesn't like having blood on the pads. And then sometimes difficulty managing the pads can be a situation, sometimes with manual dexterity, or, some patients are in pull-ups, and that's how the periods are managed. If they're in pull-ups already. Or sometimes you have to, some patients will have to be prompted to change their pad just depending on the situation. So it can sometimes be a challenging balance in the patient's ability herself to independently manage versus demands on the caretaker. And pads are often easier to use. Tampons can be used, but are a little bit more difficult and require more training. And I didn't put on here this was thanks to one of the mothers of a patient with special needs that brought this up to me a few years ago. The Thinx. How many people have heard of the Thinx underwear? So Thinx period underwear are a new product that I think is really great for special needs populations. It's THINX, and they have a great website but basically it's underwear that you wear that can absorb blood. They have different sizes, different styles, and it absorbs blood, and you don't have to wear pads. So it's there. You can rinse them out, and then wash them in the washer and reuse them. They're reusable, and I think that could, in some circumstances, can be really great. And so I've had quite a few patients of parents of special needs girls find that they really can use those successfully. And I think the downside is the cost. And so the cost is high. And just last week, I had a mom from California email me and tell me she was able to somehow get them covered by the cost of something that was providing some sort of a program through her community. So I think it's worth exploring. And I have other patients that are like 20-somethings that are like siblings of patients that are being seen at NIH tell me that from an environmental standpoint, they don't want to use pads. And so I think there's a new generation switching to this kind of a product from using pads and tampons. So menstrual hygiene, just in terms of like education, preparation, and role playing, I think there's different ways to provide that information for girls and for young women, depending on their level of understanding, and answering questions in simple, understandable way. And Matt, what is my time? 21, okay. Answering questions in simple, understandable way, so answering questions directly, and not necessarily giving extra information. Some people are visual learners, so there's some audiovisual aids that are available, and then repetition of instructions are all kind of teaching strategies, talking about like, why do we have to use pads in a girl that's just gotten her period, and just explaining it, and I'll come at the end to a resource that actually has picture descriptions of how to manage pads and how do you fold the pads to get rid of them. So even very simple things. So management of menses and contraceptive options, I put in here. Sometimes people will say menstrual suppression. So like, I'll have some parents that I'll see their daughter and they'll be wanting to know, can we get rid of these periods, because they're very hard to manage, and sometimes it'll be a situation where the person has really exacerbated symptoms, like if they have sort of behavioral aspects of their disorder that get exacerbated around the time of the period, is a like premenstrual syndrome or premenstrual dysphoric disorder that really make it hard for the person to go about their daily activities. Or sometimes they'll have really bad cramps that keep them home from school or their activities. And in some people, it's just heavy periods and hard to manage the bleeding. And so menstrual suppression is considered safe. It's done with hormones generally, and there's different ways to do it. And it's the same medications that are also used for contraception, which also in this patient population can potentially be needed also. So the risk and benefits for patients with CDG, for oral contraceptive pills or OCPs, they can be taken in a cyclic or a continuous manner. So birth control pills are traditionally given for 3 weeks, and then you have a pill, like a placebo pill week, where you're inducing a period. And they can also be given continuously without that break. And there's 2 different types: the estrogen progesterone type, which does have a risk of clot, and then the progesterone mini pill, which doesn't have estrogen and is not thought to have an increased risk of clot. There's a lot of different kinds of pills, so sometimes one won't work, and we don't exactly know why. I always tell people it's more of an art than a science to try to figure out what birth control pill might work. The good side is light or no cycles, less cramps. It's easy to stop it if it's not working or it's not needed. You have to take a pill every day, which sometimes can be a struggle, and then the blood clot that are the main risks. So Depo-Provera, the shot, it's just progesterone only, given every 3 months, and it's more convenient. You don't have to remember a pill. And most people will have irregular spotting, but will stop having periods on it. The downside, especially with this patient population, would be bone density is affected. It's decreased. Just during the time that you're taking the Depo-Provera, it seems to go back up if you stop it. There can be weight gain, some effects on mood that are hard to predict, and once you get the shot, it's 3 months that you'll have that. And then irregular spotting. Gynecologists generally will say with Depo-Provera, a third of the people bleed a third of the time, just meaning it can be hard to predict, but a lot of extra spotting. Sometimes, especially in special needs populations, people will recommend trying an oral progesterone before you step into the Depo-Provera, just to see how they're affected by the progesterone. So I'm going to try to speed up a little. So progesterone IUD it's 5 minutes. Okay, so progesterone IUDs are being promoted a lot more in patients with, in teenage patients, adolescent patients in their 20s, not for contraception, but for management of periods. And it basically decreases the bleeding up to 90%, and 50 to 60% of girls will stop having their period. So this can be, so the issues for CDG patients, I'll just skip to that. Patients will usually require sedation or anesthesia for placement. Sometimes you don't know, small percentage of people it can fall out, and you might not know that, and they might not be able to voice their pain. Okay, and the obstacles to contraception, I just want to mention, sometimes it's not necessarily something that's discussed and might need to be in young women with CDG or any disorder. And then vaccinations is my last topic. Just routine vaccinations are recommended and include HPV, human papillomavirus, and it's generally recommended for ages 9 to 26. Gynecologists generally recommend it at 11 to 12 or in the early teen years. And if it's given before 15, it requires 2 shots. If it's given after 15, it's given as 3 shots. And adolescents should be seated or lying down for 15 minutes after vaccination. There's a bit of a risk of fainting after the shot if you're getting up right away. So this resource I really like, and this is a Vanderbilt resource, and it's a toolkit for a parent's guide. There's one for boys and one for girls. So this is a parent's guide on puberty for girls and boys with disabilities, and it's a website that has these free downloadable booklets about puberty hygiene, physical changes, emotional changes, appropriate and inappropriate public behaviors, issues that are sometimes hard to discuss, and then how to use the pads. And it has a great appendix that has picture stories for kids that might not be allowing communication for different kids at different levels. And I think with that, I'd like to stop and just mention, sort of in conclusion, that I think there's special diverse needs within this population that is a very diverse population, and we certainly do need more research within this field. There's not a lot written on gynecology except for as a little section in descriptions of a lot of health of the organ systems in the bigger papers. And expanding it, the phenotype can help sort of address more specific questions that the families help to come up with. So at this point, I'd like to stop and take questions from the audience.